Hi everybody and welcome to Making Medicine Better. I'm your host Olivia Morris, and today on our panel we have Wilby Williamson, Lorna Ross and Igor Korolev. We will be discussing the impact of poverty and socioeconomic status on your health. A recent report written by the National Cancer Registry Ireland stated that people from disadvantaged areas had a 28% higher risk of death of cancer in the next 5 years, compared to those in wealthier locations. This phenomenon isn't unique to Ireland and is a huge issue across global healthcare. Our guest today, Preston Alexandra, is extremely passionate about these issues and is actively raising awareness about this topic. He is a healthcare entrepreneur and discusses how to make high-quality care affordable and accessible. Preston worked for large international medical devices companies, and subsequently in 2020, he founded his own medical device company and sought to improve clinical care and at lower costs. He has since successfully sold his business and now devotes his time to speaking with clinicians, patients, industry leaders and organisations to bring together the stakeholders who stand to effect positive change in healthcare. So Preston, hi, how are you?
I'm good. How are you doing?
Well, not too bad. Thank you so much for coming on.
It's my pleasure. Thanks for having me. I can't wait to hear from this spectacular panel and learn from you all.
We are absolutely delighted to have you on. So tell us a bit about your background and what brought you here.
Sure. Well, my background is a little different than most people in healthcare. I'd say that I accidentally kind of tripped into healthcare. I went back to school to get an MBA back in 2015, and then after graduating, found myself in a product manager role at a small medical device division in a much larger company. But I immediately fell in love with it. I thought it was fascinating, the business side, but also the healthcare side, and really found a lot of meaning in what we were doing. Little did I know the sort of monster that healthcare was at the time. And so over a couple of years working there and then another company, I got more and more exposure to the healthcare landscape. And always had in my mind that, something just didn't quite feel right as I was seeing, financials, as I was talking to healthcare leaders, hospital administrators. And I just went on a bit of a crusade to try to understand as much as I could, talking to doctors, nurses, all clinicians, and leaders in the industry. And so I launched a medical device company, really trying to focus on what I knew and lowering costs while providing higher quality care for patients. And throughout this entire time, really passionate and focused more and more on affordability and accessibility, because as you suggest in the topic that we're talking about today, obviously a big issue in the United States, a massive issue globally, is that we have wild disparities entirely predicated on people's income and financial status. And I just have always felt that to be completely unacceptable, especially in, very wealthy nations. So that's where, I saw this problem on a small scale where we were selling supplies to hospitals, and it just ballooned there for me from there. And it's what I now spend my time talking about and trying to, like you said, raise awareness and try to affect some of that positive change.
Yeah, I do see, especially, on LinkedIn, you've got a big following there. And obviously when you're talking about, the real cost of healthcare, obviously in the States, it's a little different than here. The numbers are humongous, and I see a lot of the comments from people really being surprised about the enormity of the big billions that you write about, and how it's become so much of a business and the lack of care.
Yeah, it's staggering. The number, so last year we in the United States crossed $4.3 trillion in spend on healthcare. And yet we look at it and people get really mad about it. But we spend all that money and we have some of the worst outcomes when you compare to other wealthy nations, and we lag in most of the major metrics like maternal mortality rates, things like that. But when it gets really interesting and unfortunate is that you could almost look at the United States healthcare system as 2 or even 3 separate systems. Because if you look, for example, at the outcomes compared to the spend of the wealthier, populations in the US, their outcomes are actually pretty good. A lot of it comes down to the access and the affordability of care relative to, the income capabilities of those individuals.
Lorna, what's your thoughts on this?
I think the cause and effect of things that are kind of isolated in reports like this, like I think it is, it's important to do a study. You have to kind of, you look for kind of correlation or kind of evidence that something is affecting something else. And I think this study is pretty comprehensive. But I think that there is also a lot of other things that are going on culturally, in addition to access, like people thinking about kind of health inequity around access, and certainly the privilege of wealth, and the kind of cultural aspects of kind of people who have agency and have been born into a mindset where they have expectations around access to care. And it's a lot about the kind of mindset that the patient brings into the care encounter that is really, I think, driving an awful lot. So I sometimes think that when reports call out cause and effect, they're not really touching on the granularity of what's happening. And there's lots of evidence around things like health fatalism. So I remember we worked at Mayo Clinic in particular around kind of chronic disease, but we looked a lot at the point of diagnosis and different people's reaction, when their disease is named. And you can't generalize, but I would say different people or different personalities respond to diagnosis. So there is quite a profound health fatalism when something is named. Sometimes people feel quite fatalistic, like that's it. And that can be quite influenced by cultures. And they've also done lots of studies around people with like strong religious belief as well, as an example of how it activates kind of health fatalism. So I'm not saying that's a real kind of global cause and effect, but there's nuance in what happens, how different people, depending often on culture as much as on socioeconomic, how they respond to the presence of disease. And I think that it's not so binary, and it doesn't dismiss any of the findings. I would prefer the study to have also been broader, and to say what happens a community where for generations you've lived in poverty, and every single service you've ever wanted to have access to, you've had to get to the back of the line, and you've had no agency, and you have become really disempowered culturally, and then you become unwell and you end up in the health system and you just don't know how to advocate for yourself, versus someone who has lived a life of entitlement. And that doesn't make them wrong, and they are very active agents. And there's so much else going on kind of psychologically in the nuance. And I always wish these studies could be a little bit more acknowledging the kind of edges of this. And I know it's good to make it binary and yes and no and good and bad and have not, but I really think that there's a lot more going on, and particularly things like a health fatalism and people's expectations or thoughts about if I've known someone who's had a disease and they ultimately died, does that affect how you are going to battle your disease? In some cultures, they don't believe in fighting disease. They believe that maybe that's just part of what God's will is for me to have this. And there's a sense that there's a stoicism in maybe not fighting it, or there's a kind of a selfishness in fighting it. And so I think it just is really nuanced. Certainly when we studied patients, people have very different reactions. Not everyone's determined to fight. They often have very different reactions to disease.
Okay. And now, Igor, I could see you nodding away there. Just let me know your thoughts on this.
So, yeah, I think, I come from also the U.S., very familiar with the U.S. healthcare system, as Preston mentioned. I think, each country in the healthcare system has its own challenges and opportunities. I think there are similarities, but we also have to be careful to make direct comparisons, because there are slightly different underlying factors for each one, even among the wealthy developing countries. So, for example, one thing that Preston mentioned is that access is a big reason decreased access to care, and health equity is a big issue that drives some of the poor health outcomes in the U.S. But as an example, if prior to the COVID pandemic, for example, the life expectancy of the U.S. population actually dropped for 2 to 3 years straight. And if you look at so it dropped from something like, I don't remember exactly, but it's something like 79 years old, average life expectancy. It dropped to like 78.5. So it was the first drop in like 20 years or longer. And when you look at the reason why there was a drop, there were several reasons, but two key drivers for the drop were opioid overdoses and suicides. And so that's an example of two um, challenges that are relatively unique to the US. The US has one of the highest suicide rates and one of the highest opioid overdoses death rates to any developed country. And so, in addition to equity and access issues, which is a predominant driver of healthcare challenges in the U.S., there are also these kind of, like Lorna mentioned, there are these additional cases that can't be dismissed. These are um, opioid deaths alone in the U.S. number something like 75,000 people die every year just from opioid overdoses. So, and the other thing I want to mention is kind of in a the bigger picture, when we talk about equity and access, is something that I'm very passionate about. And unfortunately, I'm a physician, but unfortunately, medical students don't get a lot of this in medical school. And that's a really unfortunate, because it's the key driver of health, and that is social determinants of health. And if you look at studies, the kind of the results vary, but generally across all diseases, across all conditions, on average, 60 to 70% of health outcomes are explained by not your genes, not your medical care. And you say, what? Well, what is the rest? Well, the 60 to 70, so genetics explains 20 to 25% of health outcomes across all diseases. Obviously, some diseases are almost entirely genetic and some are not. This is an average. Medical care that is within the four walls of the hospital or clinic, that's what we're talking about here, explains 10 to 15% of health outcomes. And 60 to 70% of health outcomes are explained by social, environmental, and behavioral factors. And so the broader picture for me is, when we talk about access in healthcare, that's part of social determinants of health. And we really need, a lot of healthcare systems like Kaiser Permanente and others are paying more attention and dedicating more resources to this area, but it's such an underappreciated area, but it also drives most of the health outcomes. So, I'll leave it there. See if anybody else has similar thoughts.
So the team have talked a lot about their experience in the States, obviously, with Preston and Igor. Wilby, you've primarily practiced in Ireland and the UK. Do you have the same experience of this inequality and access in your practice?
Thanks, guys, for your contributions. I think first, for kind of reflecting on the comments from the rest of the teams, like, we've got social determinants of health, we have culture, and we have belief systems, and then Preston kind of discussing in terms of access. And I think some of the things that resonate with me with that discussion is then the concept of agency, and having agency to be able to affect change. And unfortunately, where I see the pressures is that often the social determinants and health inequities, the impact has the highest impact on cultures and communities which have the least agency. And unfortunately, globally, then we can see that replicated in countries where maybe there isn't as strong a democracy or political agency to affect change at societal levels. And, it's fascinating looking at the US, and it's sad to see some of the stats from there. But I think it is important that we look to measure. So that, Lorna commented that, I wish these studies would go further. And I would echo that in saying that measure and then try to understand the determinants and what is it that it's truly driving those gaps. And Lorna also mentioned fatalism. I think, unfortunately, it's like fatalism in terms of how we address these issues, because they have quite a long tail. And my research and work has been life course. So I look at preterm birth and the impacts of preterm birth on adults. I look at the effects of pregnancy complications and the impact of that on offspring. And unfortunately, that's often tied into socioeconomic, social determinants and all of what we've been discussing in terms of access to care. And we see those kind of stats paid out in the US. But unfortunately, there's been then cultural stereotypes and political maybe agendas sometimes that then feed into trying to understand what is driving the social determinants, that I'd like to kind of depoliticalize it at sometimes and then actually say, let's really think about this both at a population and an individual level and look to the true causes, which are all of kind of what we've described, from culture to individuals and access. And coming back to kind of the original question in terms of UK experience, it's as Igor mentions, this is across the globe. Every culture, every society has inequity, and there's a spirit level, and that's actually the reference of a book that's a really good reference material for the audience to really engage with, to try and understand this. The health gap is another. So every society suffers from this, and it's only where you move to maybe more egalitarian societies, but then they've had quite matured democracies or matured economic systems that allow them to balance their economies and look towards redistribution of wealth and looking at more policy. But they tend to be very stable societies, and often smaller societies that have then been able to affect change. And it's hard to know whether they've intentionally delivered those as a cause and effect intervention, or that it's a byproduct, and that we now then see the benefits of those societies in terms of balancing or narrowing those gaps. So I think as a global community, we face real challenges in terms of trying to address those issues.
Just mention one thing that I remember at Mayo, we did a study around the kind of point of diagnosis and chatting with people who were kind of recent to a diagnosis, and we noticed a lot of we talked about this idea of people talking about health as something that you spend to live, and that there's a kind of that what can happen is people can start to kind of create narrative around why they're diseased, and it's a coping mechanism as well, but it's often linked to, if you have made choices and decisions in your life and you're kind of confronted with a disease diagnosis, and you kind of have to create a narrative maybe, and often it's linked to guilt about maybe choices, things you've done, things you haven't done. And it is around coping and kind of rationalizing why me. And, a really important part for humans is to make sense of something. And so you can kind of link it to the choices. And once you link it to kind of your choices and guilt, you kind of compartmentalize it. And then your relationship with your disease is very different than someone who is confronted with a diagnosis and just determined to fight it. And some people are not, because they link it back to some guilt about choices they've made, bad decisions, they've spent down their health, they've pursued something else in life, and when they have this diagnosis, they start to think, okay, I kind of deserve this in a way. And so you can't, with someone like that, it's very hard to get them to fight. And so it's back to what we said. I think that there's so much subtlety in why people have, there's definitely the gross level, yes, inequity, but I think what inequity does to the psychology, it's like, it's the experience of inequity played out in your psychology, in generations, is what's really, I think, maybe affecting people's, recovery or kind of capacity to kind of recover, as much as it is the binary access, no access. I think it's the psychology.
But just to touch on what Lorna was saying, I think while, I definitely agree that generational kind of inequity can definitely have both epigenetic effects on your genes, and as well as kind of negative impact on your agency, like Wilby was saying. I think it's important. as part of the social determinants of health discussion, as part of preventive healthcare. Health literacy and health education is a key cornerstone. I think, I think I'm really confident that if we have effective health education, that it can help empower people to take charge of their health. That's really key. I think while yes, the genetics and the generational impact cannot be dismissed, that's not to say that people are just powerless and that they can't do anything. They can do. It's just kind of getting past some of those barriers. And each person may have their own set of barriers to get through. Each person is unique. But it's health literacy is in the U.S. Health literacy for the richest country in the world. Sadly, health literacy is not great, and the COVID pandemic actually exposed some of the health illiteracy and the anti-science rhetoric that has come up. And a big solution, a part of the solution, is health literacy and health education.
It's really interesting that you say that. Only this week we were talking about kind of vaccination rates in Ireland, and we've had a near exemplary kind of cover in terms of this the early rounds of vaccination, and I think it's because of our health literacy and our rates of higher education. So I'd be really interested to understand a little bit more about the determinants of health literacy, because at that big data level and that epidemiological level, we see it carried out in access to tertiary education in Europe and North America, and then in the global south and low to middle income countries, that we then see that impact in terms of access to secondary education and transition out of primary education. And then it's interesting that then is kind of wrapped up into agency sometimes, because it's not necessarily about your understanding of your disease. It's about your ability to understand your disease and your ability to interpret information, which then goes hand in hand with that kind of that access to education and years of education, which then dominate when we're looking at this in terms of kind of scientific models. And then it's just interesting how far will that reach and how do we achieve that? Because you then get the political arguments that say, well, what does third level education mean as a conversion into employment? And actually we should maybe be thinking about that in terms of actually there's a value in promoting access to education as a societal benefit before thinking about the immediate economic benefit of does that humanities student or that literature student get a employment after their degree, because as a collective society we do see that benefit. So it's really interesting to understand kind of what are those determinants of kind of what I've described as agency, and in the kind of lay literature and the softer literature, excuse my French, but the or vulgarity is like they often coin it as shit life syndrome, because actually in the data you can see that actually as you have the pressures of economic pressure or social pressures, that then actually your capacity to make positive decisions gets eroded. And so then when you then think about interventions, that's why interventions to say reduce adverse childhood experiences or to reduce young adult trauma or young adult drug abuse, it's actually really complex and it's expensive. And so it's trying to understand how do you affect those changes, because to intervene at that level is expensive, and then you get this reaction from our current model of healthcare, which is often wrapped up into acute, while if we actually try to truly address that, you're trying to move up into that under 5 experience, and you're trying to implement positive experiences for under 5 with the mother, baby, partner, dyad, and the effect of that has then a really long tail. You're looking at the 20s and 30s, and currently our political and healthcare systems aren't really invested in or prepared to do that. And unfortunately, the experience in the UK is that we've seen contraction of funding into those early years programs, and it's a real challenge when trying to look at CDC programs and US programs that then support those young children to kind of have that first footing in terms of agency, but that agency is then as adults for them, really.
So if I can just put a question out there, Wilby, actually, I'll ask you. So the question is, what is the resolution for all this? What's the role of the government here? What's the role of individuals? Well, no, what do you think?
I think the first is the acknowledgement of like how wicked these problems are, and that they are multi-determinant. And it's coming back to kind of Igor's point, is that medicine needs to make a transition to engaging with the societal health. And I'd nearly prefer that my medical school experience had kind of taught me a little bit more about social engineering and behavior change, and politics, and how do we leverage our knowledge into action. And I think it does need collaboration and multi-stakeholder engagement and cross-party communication, and to try and remove the politics from this. And we have to get out of political cycles of 4 to 6 year terms that then determine, healthcare spending and policy. So I think it really does need a little bit more of a grown-up approach from our political leaders to really impact change.
Okay, so I'll head over to you now, Preston, here. So obviously what Wilby's just been mentioned there, do you believe that it's the government's job to resolve health equity? How do you think this should all be tackled?
Well, it's certainly a big issue to tackle, and I appreciate everything that everyone said about the topics. I think we have a big problem in the U.S., and I think, Igor pointed it out pretty well. We have really a systems problem, and it impacts the system. The global system operates in those same kind of ways. When we talk about healthcare, we talk about access in the United States, we're talking about, can you go to the hospital? Can you get a lab test? Can you see a doctor, right? As Lorna mentioned, binary, access, no access. There's certainly a sliding scale to that, but more or less, someone has less and someone has more. But we don't talk about is the systems that drive all that, sort of what Igor was mentioning in terms of social determinants of health. That ties into the systems level of what is really driving all of that. And how we don't identify or define healthcare, especially in the US, is all the other stuff: housing, upward economic opportunity and mobility. As everyone else has mentioned too, agency, or the cultural differences that people have and how that interplay affects what people's decision making and autonomy is, and what they're able to do, speak for themselves. Education, again, part of the broader systems that hinder individuals and societies in general from moving forward, from having those voices, from taking more control. These are all really big systems problems. So when you say, how do you fix this kind of problem, or whose job is it? I think it's really, really hard to answer, because you can look at it. I think I look at it from like two different ways. We can look at the politics and say they ought to do something about it, and but that doesn't really get us there. I don't think. We can vote, sure, but we also know kind of that's a big system too, and that's a system that disempowers people. And we have laws in the United States that support gerrymandering, which basically means drawing of districting lines so that certain individuals can stay in power, or parties. And we have a mess right now that we're all very familiar with of party politics, especially in the United States. It's kind of embarrassing, but it is what it is. So from a political perspective, it's hard, because it's just always gonna, it's trending towards the direction of you versus me. We can't agree, even if we do agree. And, we can vote up and down, but we have always just kind of two choices at the end of the day. So outside of that, it's like, okay, well, what can we do about it? I think a way forward is to address it from the outside. And what that really takes is a culture shift at a very high collective level, to really impact those systems. Because again, if we think about systems in healthcare, or economic, et cetera, they all operate. It's all subsystems operating within much larger ones. In the United States, our sort of predominant large system is a capitalistic system. I'm not on here talking about we need to tear down the capital society and burn things in the streets and whatever. But we do need to take a hard look at that system and the role. It's hard, but it's sort of the role that we each individually play within it. Those of us who are capable or in a privileged position to say, I understand the systems, here they are, I recognize them, and how can I start to make different decisions to help other people see the systems? Because once you make them visible, I think that you can really start to make either different choices or work on those problems, whether it's, practically speaking, starting a company that you think can be disruptive, or joining one, or going to work inside of a healthcare system to change that microsystem within the broader one. You can start doing those types of things and then helping spread awareness around that to help other people kind of maybe get on board too, or maybe rethink or pause. So I think that's maybe the more practical thing, that's by no means like, hey, this will be done in 4 years, to speak in political cycle terms. But, this will take a lifetime. This is a generational problem. And so that's my opinion, nascent as it may be, inexperienced and unlearned, but that's kind of how I see it.
Now, obviously, you post about this an awful lot. What are the people that are coming to you asking for? What do they really want to know? It's sort of a mixed bag of people that come to talk to me. I get a lot of feedback from clinicians, actually, for the most part, and some people too who are sort of in the industry and they want to know how to start a medical device company or something, which is something totally different. But it's sort of, what are the thoughts around, on an individual level, what can we do? How do we get out of this thing? It's so broken and beyond. And I talk to a lot of nurses and doctors a lot about my views about having more clinicians in non-clinical leadership roles and developing that systems thinking approach. Because again, it's all subsystems within much larger ones. But if we can start to turn those tides and say, and I'm talking to a couple of doctors on this panel, and they probably have this mindset, but a lot of doctors that I've talked to, at least nurses and clinicians, don't, is that who better to know about what patients need. Obviously patients know what they need a lot of cases, but you could argue that we'd hopefully have the type of system where people who are sick and don't have that medical knowledge and nomenclature can go and say, what do I need to do? And they get the right answer, right? In a perfect world. But those clinicians who can then say, I know all this stuff, I've seen a lot, I've helped all these patients, quality outcomes, etc. But we have this whole big machine of business that runs medicine right now. And so to get those practitioners who understand the challenges, the lives of their patients, into those positions where their business decisions making directly impacting the practice of medicine, that to me, that's a lot of the folks that I talk to and that I want to talk to, because I'm super passionate that we need more clinicians in non-clinical leadership roles to start to change the balance of the business of healthcare.
If you don't mind, I'll jump in. But I think Preston and Wilby and Lorna were mentioning, it's also, I think the key is, no single stakeholder will have all the answers. And it's all about the perspective problem, right? While I agree with Preston that clinicians should, the key word is should, know what their patients need, that's not always the case either. Because clinicians and physicians, we do know our patients pretty well, but not as well as we should. Why? Because there's just not enough time. We have our own challenges that we're dealing with. Clinicians, for the most part, unless you're a social worker or a clinical social worker, or don't really get into too much of the social determinants of health with patients. not because we don't want to, not because we don't recognize the importance, because there's just within the limitations of the system, there isn't enough time for that. And that's really unfortunate and unacceptable. So I think ultimately no single stakeholder in healthcare will have the answers. It's bringing multiple stakeholders, whether it's patients, caregivers, insurance companies, pharma, biotech, clinicians, uh, everyone around the table that has a vested interest in healthcare, as well as policymakers, and coming to reasonable solutions. And the other part of it is what makes healthcare so difficult, and that you said, the question that you asked, Olivia, is, what is the solution? How do we solve it? Again, it goes back to the multi-stakeholder, multi problem, because healthcare, by the nature of it, is embedded in the rest of society. It's not healthcare in a vacuum. Healthcare, because of the effects of the social determinants of health on health outcomes, is intimately tied with the rest of society. So you better believe that if it's a more developed, more democratic, more socially just society, that they're going to have better health outcomes. That's just a given based on how health and healthcare works. And so it's a difficult challenge to address, because it depends on an economy, on country's economy. It depends on the multicultural and diversity aspects. For example, some of the best healthcare is usually in Scandinavian countries, Norway, Finland. There's a couple of others that have terrific healthcare systems, and so what can we learn from that, for example? But the issue is, those are relatively homogeneous societies, and their populations are like under 10 million. So the question, I think we should learn from anybody from different industries, from different countries. But the question is, how do you take a healthcare system that works wonderfully in Sweden or Norway, which is always in the top 10 healthcare systems, and how do you spread that to population of 330 million, much more diverse society, 50 different states with different regulations? And that's the challenge. The challenge is multifactorial.
Yeah, definitely. I mean, I totally agree with you. It's, about multiple stakeholders, multifactorial. But I don't know, and I mean, in terms of like the comparison, I know I kind of kicked it off with like, oh, the U.S. is the worst, and we rank the worst comparing to these other nations, and we do want to always say, well, what if we just had a healthcare system like Germany, for example, or the Nordic countries, like you're suggesting? But the point is important that we're very different countries. We do have 300 million people. We have, I don't know, however many 100 million square miles. 47% of our population lives in rural America, which is an enormous swath of land and is very challenging. But I don't know that we necessarily need to say, how do we adapt XYZ healthcare system to our healthcare system? I think that, sort of as you point out, more importantly, it's, what is the strong society that we want to develop and create here? Because it is much more than just we all have a primary care doctor that we stay with for 15 plus years, and we have a great relationship, and they spend more than 7 minutes with us once a year during our physical. It's those types of things where we invest, like Wilby said, in very early childhood interventions, in education. I mean, there's studies out there that I've seen. I take these all with a grain of salt, but every dollar invested in early childhood education is like a 12x or something ROI for either the economic output or of that individual. So it's really more than saying and looking at these countries like, oh, they do healthcare better. But I'm just kind of wrestling with and always thinking about, well, is this even about healthcare as we define it now, or is this about creating that strong, vibrant society that we need, and accepting and embracing all the cultural differences, the rural, changes, and far distant individuals who live in ranches in Wyoming, or the very family focused, Latina cultures that live near the borders in the South, and really developing just a different perspective on how we work together as a society to make it stronger, and will as almost as a byproduct of that positively impact our health and then subsequently health outcomes.
I think that's such an important point, Preston. It kind of brings us back to Lorna's points in terms of, cultural diversity and cultural sensitivity. I'd be really interested to hear Lorna's point of view, because that's a really nice segue back into kind of where Lorna started the conversation.
Well, yeah, I think, probably a couple of things. Having lived in the States, grown up in Ireland and then spent 27 years in the States, and I love both places for lots of different reasons. But I think, you think about kind of the the kind of European, we skew much more into kind of socialist cultures anyway. And I think you have North America, which is deeply capitalist, and it's shaped the culture as much as, the economy has shaped the culture into really isolating the individual. There's that kind of sense of, corporations are shaping cultures, and they're allowing shape childhood and really keeping people. And I think, Preston, you're so right. Really creating very polarized, very isolated, very agitated communities where people perceive threat from each other and not driving, solidarity together. And it is a scale thing as well. But I think you've got like socialist bias in cultures like the Scandi, and so I think what's playing out in their healthcare is because it's more of a socialist model. And I think a little bit with what Wilby mentioned about the kind of uptake of vaccinations here was because ultimately we trust the government. We're part of the EU, we trust the government, we believe they're acting, so we have that. So I think, just again, I would agree. I think you're comparing political landscapes and political mindsets and people being so manipulated by the politics. And in the States, the politics is driven by economics. It is, there's no real politics. It's just capitalism. But I think, Wilby, to your point, coming back, my work was always really about trying to understand, particularly the patient. And one thing that really struck me a lot about, we did a huge study of chronic disease and tried to understand, people who were kind of managed in their chronic disease and weren't, and we would spend time in their homes and communities. And this was in Mayo Clinic's in Minnesota. So again, Preston, to your point, really rural communities, farming communities. And, health for a lot of people was a real set of trade-offs. I think it's, again, nothing in life. I'm not a big fan of binary, so people would kind of understand what they were being asked to do in terms of like lifestyle changes and stuff, but they would also understand the impact of having to maybe give away something that was socially or culturally meaningful to them to, adopt a new habit. They might isolate themselves from their community if they had to stop doing something. They were so aware of that trade-off. Like they weren't, these are smart people. They just knew that they, given the choice, they would choose community and they would choose family and they would choose, things. And it looked like they were deviant. Clinically, they looked like they were kind of opting out. So again, I think an awful lot of people managing their health is a set of trade-offs. And so when confronted with a kind of health system that is optimized for someone who's really opting in, and I think that a lot of care is designed for the 1%. Like I think it's designed for the best case scenario versus worst case. And it's a model that if you can embrace it in its totality, it will work for you. And if you can't embrace it, it's not going to work for you. So I think it's designed for the privileged. I think a lot of care is designed for people who can opt wholesale into it and put their life on hold and suspend everything and, manage and then come back to life. And some people life doesn't stop when you get sick. And their only way to cope is to, make trade-offs about how much they can actually deal with an illness. And they just have to live with it. And so I think then you have reports coming out about, this, person with wealth lived 2 years longer or had kind of greater health outcomes. And I just think there's so much about the system itself is really designed to be, and I think, Preston, you're so right, it's a business, right? Like healthcare is a business. It's not a charity. It's a huge, industrialized medicine is a massive industry, and it's designed for people to opt into it, like to kind of engage and to opt into it. And so I think, if you can't opt into it, you don't really matter. Like, it doesn't care about the customer who can't use its product. So it's targeting the people who can. And so I think that could be skewing it as much as anything, is why it's being designed. It's being designed for people who it resonates with as a model. And they also happen to be educated and privileged and entitled, and, they have the capacity to kind of connect with the system. And those who can't are kind of irrelevant.
Yeah, I think one thing we've learned, even going through the episode here today, is that this is an absolutely huge topic, one that we definitely can't cover in one episode, I would say. But we will have to wrap this up. I guess, Preston, I have to say to you, are you ready to come back on? Because I think we're going to have a round two.
I'd love to, if nothing else, to just actually sit and listen to everybody else, because I just learned a tremendous amount and feel like I shouldn't be taking up the airwaves with what I have to say, but just want to learn from everyone else.
I mean, I just want to say, even for me, reading what you do on LinkedIn and what you do for clinicians everywhere, it isn't just the States. Your voice is loud and it's going places, and you are making a difference. And I'm so glad your voice is on here today with everybody else's. And I can't wait to have you back, to be honest. I'm so excited to have you back. But for today, I just want to thank you so much for your time, and happy birthday.
Happy birthday, Preston.
For all our listeners, I hope you enjoyed today's episode. And if you have any questions for our panel or for Preston himself, get hold of us directly, or you can visit us on mmb.fm. Don't forget to follow us on social. All links will be in the description. See you next time. And as always, keep making medicine better.